Thank you so much for the invitation from the Imperial team, and it's a real pleasure to be here. And particularly that I managed to time my arrival to a delicious lunch as well. So it's really great to be here now. My title is endocrine disease, but I'm going to focus on talking about diabetes and about the research that my team are doing, which I hope is going to be of interest and relevance to you. So I'm a doctor. I work at Barts in East London. I specialise in diabetes, but increasingly I am a researcher. And that's because over the course of my career, although I love being a doctor has left me with a lot of questions and a lot of things that I want to know more about, aspects of healthcare that I'm sure you all are more aware of than me that aren't right and need full knowledge. And so as my career has gone on, I've increasingly gone into research to try and address some of the big questions that I think are relevant in relation to diabetes and in relation to populations who are underrepresented in research. Can you hear me?
Yeah.
Okay, great. That sounds a bit better now. I'm hearing yourself, Adam. I just need some. Here we go. Right. So this is what I'm going to talk through. I'm going to try not to talk too much, although I do have a tendency to talk a lot. So, but I'll keep myself in check, and hopefully there'll be some time for some discussion and questions at the end. So I'm going to go through a little bit of background just about diabetes and why I think it's important. And then we'll talk a bit about the connection between sickle cell disease and diabetes. And I have to put my hand up and say I'm not an expert on sickle cell and diabetes. I think it's actually the sickle cell doctors and nurses and teams that are more expert on this topic than I am. And actually, in the course of putting this talk together, it made me really think about my own knowledge and the lack of knowledge on these two conditions together. So for me, this has been a real eye-opener, if you like, and has got me very kind of interested and passionate about the subject. I'm going to focus a little bit on diabetes checks in sickle, okay? And then I'm going to move into why I think research is important, and I'm going to tell you about our study of Black Health Legacy, which some of you may have heard about already. Okay. So diabetes, just in basic terms, is all about glucose or sugar in the body, okay? And every cell in our body uses glucose as a fuel to work, to what we call metabolize. And insulin is the hormone, again, that we all have in our bodies, all over our bodies, that is a really key factor in how our glucose moves in and out of cells, okay? And insulin is required almost like a key to lock them and unlock the movement of glucose in and out of our cells for them to be able to use glucose as a fuel. But in diabetes, this system breaks down, and it can break down for a number of different reasons, and I'll talk through that a little bit. But for some people, it's about not producing insulin well enough or enough, and for other people, it's about insulin not being recognised within their bodies, and for some people, it's a bit of both. Now, just a few facts here. You probably are all very, very aware of health inequalities experienced by people living with sickle, but also more generally people from Black communities. And this is an area that I do a lot of work on and I'm very passionate about, which is why do we have these stark inequalities in conditions like diabetes affecting, for example, Black communities. So we know that for type 2 diabetes, and I'll explain what I mean by type 2 in a moment, it is 2 or 3 times more common in the UK. It's not just more common, it comes on at younger ages. And the complications of diabetes, things like eye disease and kidney disease, are also more common. Okay, so yet another one of the long, long list of inequalities faced by Black people in the UK, this in relation to diabetes. Okay, so let me just briefly, I go on and on about type 1 and type 2 diabetes, and I find it helpful really to explain a little bit about what I mean by that, because these terms can be quite confusing. Now, type 1 diabetes is a very, very specific condition, which we call an autoimmune condition. And that's where the body's own immune system mistakenly attacks the cells that make insulin, and those cells are in the pancreas gland in your tummy. Okay, and what that leads to is somebody's body not producing any insulin. Okay, and what that means is that blood sugar can't get into cells, the blood sugar levels go really high, and people with type 1 diabetes need to take insulin to replace what their body is not producing. Okay, so this is largely an immune condition. And it often runs in families because there is a strong genetic component to the condition. We also think there might be some triggers from things like infections early in life, but that's not something that we're particularly sure about. Okay. Now, type 1 diabetes is the uncommon type of diabetes. So of all the people in the world that have diabetes, people say it's about 1 in 10. It's probably actually more like 1 in 20 or even less than that. It is uncommon, but probably all of you know somebody that has type 1 diabetes and has had it since they were a child and have had a really tough time with it. Okay. And it is less well studied in a global context. Okay. But in the UK, we have very specific NHS pathways for people living with the condition, and I'm pleased to say that with a lot of new technologies like insulin pumps and glucose sensors, our care of people with type 1 diabetes is improving. Now, type 2 diabetes is really the big and the common one, okay? And this occurs when the body's cells stop responding to insulin, and we call that problem sometimes insulin resistance. Our cells are resistant to the insulin that our body's producing. Okay. And then what happens as a result of that is that our bodies try and make more insulin to overcome that. Okay. And then eventually the pancreas is having to work so hard to produce more and more insulin to overcome this resistance that the pancreas gets exhausted, okay? And then actually you don't produce enough insulin. So you have kind of two big features of type 2 diabetes, okay? And this is a complex, when you look at the kind of all the biology underlying type 2 diabetes, it's really complicated and we don't have full understanding of all of it, but it involves things like the muscles in our bodies, our liver, our fat tissue, and that insulin resistance problem is occurring in all of those tissues, okay? So that's the kind of glucose aspects to type 2 diabetes, but there are some other ones. It causes a bit of inflammation in the body. It causes our tummies and our brains to perhaps not talk to each other so well and tell us when we're hungry. And it also affects how we turn over and metabolize fat in our bodies. Okay. Right, now, type 2 diabetes is the one that it also has a very strong genetic basis. But it is the condition that we also associate with what we generally call lifestyle factors, so particular ways of eating or lack of exercise or becoming overweight, okay? It's not all about those things. There's a huge genetic risk, so it's not about blaming people that get type 2 diabetes, but those factors are important. Now, why am I talking about diabetes at a meeting with people living with and interested in sickle cell disease? Well, diabetes is important because there is some overlap in the conditions and particularly around the complications of diabetes. So if we just focus again, I'll come to sickle and diabetes a little bit more in a minute. But one of the reasons diabetes is important is because the longer you have diabetes and the more kind of elevated or the higher your blood glucose levels are over time, the more that leads to damage in small blood vessels in our eyes, our kidneys, our nerves, but also big blood vessels. So our heart, the blood vessels are supplying our brain, and that can lead to heart attacks and strokes. Diabetes is also important because it is a really tough condition to live with, whichever type you have. And we talk in medical terms about treatment burden, yeah? With type 2 diabetes, the longer you have it, the more treatment you need, yeah? And people are taking multiple medications as well as things to treat the diabetes, but also to protect their blood vessels and prevent heart attacks and strokes. And it is hard, and I'm sure there are some of you living with type 2 diabetes in the room, and you know how hard it is. And just managing the condition, not just taking all the tablets, but monitoring your blood sugars, going to the doctor, having all the checks, it's hard work. And we see that having a real impact on quality of life. It can cause psychological distress, depression, anxiety. And if you have this complication, sometimes that can even lead to disability. That's all really grim and negative, isn't it? There is some good news, yeah. You can take control of diabetes. You can't, there is not a miracle, but there are aspects where you can really make a difference. Okay. So if you get your diabetes diagnosed early, you can sometimes even put the condition into remission. Okay. And that's where you hold it back by perhaps losing weight. Okay. Or doing a lot of exercise. And so that is something that we can see now can work for some people. Equally, type 2 diabetes can be prevented if somebody is on the way to developing it. Those interventions can also. But also, if you do get diabetes, and of course, if you're living with other conditions like sickle cell disease, it might be really difficult, extra difficult to manage your weight or to exercise. So those things may not be an option, but actually if your diabetes is picked up early, we can do a lot about it. We can intervene early with some good medications that not just treat the diabetes, but also protect you from complications. And we're very proactive in diabetes about managing conditions like blood pressure and cholesterol at the same time to really lower the risk of those complications that I talked about earlier. Now, what about sickle and type 2? So I've talked about these two types of diabetes, type 1 and type 2, okay? And yes, those are two distinct conditions. And as people get older, they're more likely to get type 2. And increasingly in sickle cell clinics and sickle cell care, we're seeing more and more type 2 diabetes as people age with the condition and as all of our lifestyles change and we all eat good lunches and put on a bit of extra weight, yeah. But there are some features of diabetes in sickle that are a little bit different and fall between that type 1 and type 2 diabetes. So for some people with sickle, all of the blood vessel issues that can happen can sometimes, not always, but can sometimes damage the pancreas. Okay. And that can lead to some features a little bit like type 1, where the pancreas is not producing enough insulin. And that can mean that some people with sickle and diabetes actually need to progress onto insulin treatment sooner than someone with straightforward type 2 diabetes. Equally, if you're someone having a lot of blood transfusions, that can also cause some iron overload in the pancreas that also results in similar things. But there's also challenges to managing the condition, like some medications, hydroxyurea, some of you may be on it, we think, not sure, might impact glucose levels a little bit, not a great deal, but a little bit. And for those people who are having acute chest crises and may occasionally be on steroids can also push people into diabetes. Okay. But then there's this really big story, and some of you may be very well aware of this already, but the big issue we have is that some of our diabetes checks, our diabetes tests, are inaccurate if you have sickle. Okay. And I'm going to talk more about that now. Okay. Now, this is not a story about sickle. This is a story about something called G6PD deficiency. Okay. G6PD deficiency is caused by a small gene change that is common in black men. And the reason it's common in black men is because it is what we call an X-linked chromosome, X-linked condition. So it's on if you're a man, you only have one X chromosome, and therefore if you carry this gene change on the X chromosome, it's more likely to have an impact. The reason it is common in black people is for the same genetic reasons that sickle and other conditions are more common in black people. It's because over time it has evolved to protect people from malaria. Okay. Now, G6PD deficiency, unlike sickle cell, is not a serious problem. Okay. And the majority of people with G6PD deficiency do not know they have it. Okay. And it is only in recent studies, with research becoming more participatory with people from black backgrounds, that we've learned just how common G6PD deficiency is. And it turns out that 1 in 7 black men in the UK have G6PD deficiency, but only 1 in 50 of them know they have it, because as I say, it doesn't cause really any major medical issues. Now, why am I telling you about this? I'm telling you about this because G6PD deficiency also causes some changes to the red blood cell. And what we've learned in our research, and that has led into us setting up this study called Black Health Legacy, is that because G6PD deficiency affects the red blood cell, our common diabetes blood test called HbA1c, which essentially measures how much glucose or sugar is stuck to a red blood cell, that blood test doesn't work, okay, and it is really inaccurate. And in G6PD deficiency, it lowers the result that we get from that diabetes blood test by a really significant amount. And in our research, what we've shown is that that means you might be a black man who carries G6PD deficiency, doesn't know about it, maybe you're getting a bit thirsty, a bit tired, you go to the GP, you have diabetes check, your GP says you don't have diabetes. Okay. But actually the test isn't accurate, and maybe you do. Okay. This is, we think, a big cause of health inequalities in diabetes for people from black backgrounds, particularly black men. Now, why am I telling you about this? I'm telling you about this because, first of all, this is affecting 1 in 7 black men, but it is a similar reason that this HbA1c blood test does not work if you have sickle. Okay. Now, the good news is that the sickle community and the sickle healthcare professionals know that already, okay? They're well ahead of us, okay? And they know, and actually if your sickle team are doing a diabetes check, it's unlikely that they'll do this test, yeah? But actually if you go to your GP and have a diabetes test, they may well not know that, okay? And these kind of issues are only now coming to light, okay? Now, so what I've said here is that are your diabetes checks, if any of you have diabetes checks and you're living with sickle, are they inaccurate? So yes, and what do we know already? Well, we know that sickle cell gene carriers, and that's people with sickle cell disease, but probably also sickle cell trait. Are there issues with this HbA1c blood test? Yes, there are. Okay, but do we know what to do about it yet? Not really. Yeah. And we need to really urgently do work, and some of that is research and some of that is clinical improvement to know what to do about it. Okay, so what should any of you do? Okay, first of all, please carry and hold this knowledge and share it. Yeah, and don't be afraid of sharing this knowledge with your doctors, with your teams. Okay, and please, if you say to your GP, hang on, you're doing a diabetes test, do you know that the HbA1c test is inaccurate? All they have to do is Google it and they will see, okay? So please carry and share that awareness and share it with family members who have trait as well as disease, okay? Probably it's a smaller impact if you've got trait, but I'm sure there is an impact there as well, okay? There are some alternative tests we can do. None of them are perfect, but there are some alternatives. And there are things like just measuring glucose directly, a fructosamine test, which is an alternative, also doing some finger prick testing, or even wearing one of these glucose sensors that we use a lot now. Okay, so I'm going to now move on to research. I hope, set the scene to say, and you all know this, there is a lot we don't know in medicine, and there is a lot we should know, okay? Now, this is really what drives me as a researcher, okay? And there is tons in diabetes that we don't know, and this is one of the big areas of focus for me and my team at the moment, is how do we diagnose and monitor diabetes with tests that actually work, and that don't just work for white people, that work for everybody, okay? There are other things we need to know about sickle and diabetes. What treatments for diabetes work? Are they all as safe as each other if you've got sickle? Okay. And how do we make the diabetes care of people living with sickle as good as others? 5 minutes, that's all right, I'm nearly done. Okay. And then how do we then make our checks and our management of diabetes more personalised? Okay. Now, this is where research comes in. This is a complicated graph, but this just shows over the last 15 years how many people around the world have participated in genetic studies, okay? And I've set the scene by saying that sickle and G6PD deficiency are genetic conditions. You only really find out about how common they are if you have good genetic studies. But equally, all of our medicine in the NHS is moving towards using genetics to make it more personalised and precise. So we need genetics. Now, this big sweep of red is the increase in participation in genetic studies around the world over the last 15 and 20 years. That red is white people, Okay, so there are tons and tons and tons more studies that involve white people. Great for white people. Where are the black people? That little thin purple line, you can barely see it. So there's less than 1% of the world's genetic studies include people from black backgrounds. Okay, so everything that we are developing with the knowledge of genetics is going to be based. Okay, yet another cause of health inequality. So this is really why Black Health Legacy exists. This is a study that we lead at Queen Mary with partners all listed along the bottom, and I'm delighted to say Dr. Okoli is one of our partners, and many of the people here are involved in the study, which is fantastic. And I'm co-lead Black Health Legacy with my colleague Dr. Barts, and these are some of our partners and team members here. I'm going to play you a short video just to wrap up in a sec, just to tell you a bit more about the study. But this study is designed, and our mission, if you like, is to change the story, okay, is to involve people from black backgrounds in a research study that overcomes all of the historic and still current issues with representation, bias, exploitation, and all the negative things that have occurred in research studies that have involved black people over the years. And we want to change this through a research study that is community embedded, and that is built together. Okay. And our initial focus is on diabetes, and I'm just going to, with Olivia's help, play this short video. Is there some volume by any chance? Or have it been Jesus. So that's the study. I've run out of time, so I'm going to just yeah, we'll do the Q&A. So this, there's just one. So as we've said on the video, this is a very easy study to participate in. It takes about 10 minutes to sign up. You can sign up via your clinic if you're Imperial, possibly even today. I think we have some research team members. And our initial priorities are to work on diabetes, blood pressure, and kidney disease. Okay. And we've been going just 4 or 5 months, and I'm pleased to say the study is going really well. We've had fantastic feedback from people that have already participated, and we've already included and recruited 600 people to the study, which is phenomenal. So we are very keen to be working with the Sickle community because of these links between Sickle and diabetes, and we're really keen to talk about how this is a study that could work for you guys as a community and really drive change. Okay. So I will leave things there, and this is just our contact details here.
I'm not going to speak for anybody, but I think I'm going to sign up for this. So diabetes does run in my family, and every time I go to my GP and we do one of those tests, I said, I'm not diabetic. I'm sure I'm not, that's sweet enough, but we will be taking questions. actually probably running the microphone for me. But don't be afraid to put up your hands. Don't be afraid to ask questions. Dr. Pan is here and we've got Finley. So go ahead. Questions.
You see it? Yes, my name's Greg Davis. This is Sonia. We've come up from Bristol. It was interesting listening to you bring that. Do you have any information that we can take back?
I do. Yes.
Okay.
And somebody at the back is waving their hands.
Oh,
Yeah, and
brilliant.
I've also got some leaflets as well.
Right.
We are currently only set up in London. Yeah. But later on in the year we will be opening up nationally, and Bristol is one of our key target sites that we'd like to open up. Yeah. I've said that you can participate from home. We're not quite live on our website with that, but that will happen over the next month or so. And if you're ever visiting London during the week, you're always welcome to come and visit us and sign up there.
Just quickly add, sorry, just get back of the room. So if anyone is interested in participating, we can make that happen for you today, right here, right now. So we have a limited number of kits, so we can talk you through the study and what it involves. Very simple. So come and speak to myself or my colleague Tan.
Don't be shy. You're all beautiful.
And so it's sorry, a very, very informative presentation. Good question. My first is just for the audience, what happens to that sample that they give you?
Great. So we do two things. So when you sign up to Black Health Legacy, you go through some paperwork with you. We have an information sheet which has a lot of information in it. We deliberately put a lot of information in, particularly around what we do with your data, yeah, because we don't want to hide that stuff away, okay? So there's a lot in the information sheet. Now, I've said it's quick to sign up, okay? It's quick to sign up because we take just a little bit of information from you, okay, and we just collect this saliva sample, we don't take a blood sample, okay? Now, what we then do, when we've collected those things, we take that information back to our research centre based in Queen Mary, okay, and the saliva sample is then turned in the laboratory into a DNA sample, okay, and we process that to be able to analyse gene patterns across your DNA, okay, and with the information you've given us, like your name and your NHS number, what we then do is we link to the information that the NHS has about your health. Okay, so what conditions you have, what year they were diagnosed, what medications you're on, things like that. Okay. Now, it is entirely appropriate for you all to be sitting there, and I would be thinking, oh my God, okay, how do I know they're going to be doing that safely and securely? Okay. Now, for us as a team and as a study, the security of that information you give us is an absolute top priority. Okay. And we will not build trust in a study like this unless we are holding that information with the care and attention it deserves. Okay. So you have to give us, when you sign up, some personal information, but as soon as we possibly can, once that's reached our system, we take all of the identifiable stuff off. So your name, your date of birth, your address, your phone number, your NHS number comes off, and we store it in a very secure database called a trusted research environment, which has the highest level of regulations around it, not just UK and GDPR regulations, but it also meets international data security regulations. Okay. And the personal information is only accessible by myself and less than 10 people in the core research team, and in a very secure location. We have to have some personal information to hold so that we can then recontact you and say this is what we're finding and this is an update on your study. But it is a very, very limited number of people that can access that. And the links then between your health information and your genetic information are also only ever made in an anonymised way. Okay, so I can't have a conversation with you, Stephen, and say you participated and I got this to objection, yeah, because those links will be in place. Yes, please, yeah.
Because you mentioned that at the end about
Yeah.
Communicating with the community of contributors,
Yeah.
basically contribute to their samples. Now that's really, really important.
Yes,
And I
absolutely.
think that's one of the challenges
Yeah.
we've had with previous studies where that
Yeah,
information
yeah,
hasn't been communicated.
Yeah.
Just wanted to ask how that
Yeah.
tends to do.
Absolutely. So, there we have a number of plans. We've only recently set up. Okay. And for those of you that participated in research before, you're probably well aware that it takes people like me sometimes many years to make a discovery. Okay. That's a real challenge, isn't it? Because you're giving a lot by joining a study and you're giving a lot, not just personally, but, you know, for future generations. So you want to be sure that we're going to actually drive some change and that also we're going to tell you about that. Now, the thing that we're working on at the moment is a regular newsletter that's going to go out, okay? And that will be going out via MailChimp, and that will be, even if we haven't made a discovery, it will be an update on where we're at, yeah? And what we've been working on, and, you know, that we've just set up in Bristol or that we've worked with a new team. And those are updates we feel are really important. And researchers typically wait till they've discovered something to tell anyone about it. We're not going to do that. Okay. The second thing is that we have this very core community infrastructure in the study. So we have a community advisory board, okay, which work with us at a senior leadership level to guide what the study does, okay, and that involves a number of representatives from Black communities, Black-led organisations to help steer us and also to make sure we're getting that kind of thing right, okay. And then in addition to that, we've got some ambassador roles, okay? And that's a new thing, and we're just getting ambassadors on board. But the aim behind having this ambassador scheme is that those ambassadors can help us make those links to be able to keep the conversation going. Yeah. Not everybody reads newsletters. I know I don't always. So some of this is about conversations. And I will say we've been to about 80 community events, meetings over the last 4 or 5 months. The rest of the team are in South London at a health event this afternoon. We as a team are really committed to this kind of thing. Yeah, I actually love coming to audiences like this to share what I'm doing. It's a real pleasure for me. And so I think, you know, for as long as the study is going, yeah, we want to be able to come back, yeah, and say, oh, this is what we talked about last year, this year, this is where we've got to. Okay. So we do have a really strong commitment there. And I know I've been in research studies myself when no one's told me anything. Yeah, we really are committed to that. But please also, you know, challenge us with that. I've given you our email address. If you've participated and you've had nothing, you know, get in touch and say, you said there was going to be a newsletter. What's going on? Yeah.
Okay, thank you. Sorry, we don't have any more time. But is there a way that we can reach you?
Yes, best thing is the Health Legacy email. Yeah. And then because we're not a big team, but then queries can either come to me or come to a team member, or equally you can look me up. My email address is the same, QMUL NBIT, and it's s.finer. So feel free to contact us, and I'm on LinkedIn and the studies on LinkedIn as well. We're not yet on other socials, but that will be.
Great, thank you. Thank you again.